I'm Dr. Leslie Miller. I'm currently the Director of Heart Failure for the Baycare Health System here in Clearwater, Florida. I think many people could tell you that cardiovascular disease is the leading cause of death, not in the United States, but in the world. But I think many people won't recognize that heart failure is the fastest growing form of cardiovascular disease. In the United States alone, there are almost 1 million new cases of heart failure every year. The American Heart Association did a really intense projection of looking at what we should estimate to see, and they suggested a 46% increase in these already high numbers by 2025 to almost 10 or 11 million people in the United States affected by heart failure. And the cost of care is projected to go from $32 to $70 billion a year just caring for these patients. It's the #1 indication for hospitalization, people over 65. And one of the markers of we don't have much to offer these people aside from very radical therapy like mechanical device and so forth, is it's the #1 cause of readmission. By the time a patient begins to require hospitalization on medical therapy, there are very few meaningful options available to them, and why we're so interested in cell therapy as a broadly based, easily to deliver type of therapy that may make a significant difference in potentially literally millions of people's lives. The manifestations of heart failure are pretty common. They are directly primarily related to congestion. When the heart pumping function isn't very adequate, pressure builds up, it goes up to the lungs, it causes congestion, which translates to shortness of breath. And it's variable in people that it could be early class 2 only when I do something vigorous. Class 3, it's I don't have to do very much, I don't walk. And we describe the funnel phenomenon, that someone has measured continual decline in function, and yet they say, I'm really not having much trouble. It's because they progressively restrict their day-to-day activity because they know that will prompt shortness of breath and uncomfortable symptoms. I've spent the first 2/3 of my career focused on patients with really fairly advanced heart failure, and the modality that was effectively used is heart transplantation, a total replacement. Only about 2,000 a year actually undergo that procedure, or mechanical assist devices, and that's come through a lot of evolution. They're much more effective. But when you realize epidemiologically how many people you can effectively improve significantly versus the 150,000 with fairly significant advanced heart failure, it was a really trivial type of application of those advanced therapies. The CardiCAMP trial is a phase 3 trial, meaning that if this is positive and shows benefit over the control group, it will be able to be commercialized and available to patients ordered by their physician. It's focused entirely on patients with ischemic etiology or have had a previous heart attack and blockages that have led to a loss of pumping function in the heart and relatively symptomatic heart failure. The study has a number of attributes that I think separate it from other trials previously. In particular, the FDA mandates whether it's a drug or a cell or a device that it's randomized pretty much equally 1-to-1 to control group versus the treatment group. This one is fortunate in that it's a 3-to-2 randomization, so a patient who would get into this trial has a 60% chance of getting their own stem cells. This is a trial that involves their own autologous bone marrow-derived stem cells. They're studying a particular type of cell that is very helpful in patients who have blockages in their coronary arteries, in that it's the so-called endothelial progenitor cell, which is the cell in the bone marrow that is responsible for development of new blood vessels. Unfortunately, people who've had a heart attack, there is no stimulus to form new blood vessels. You get collateral blood flow with exercise and time, but many of these patients have diabetes and other forms of atherosclerosis that limit blood flow. And this study is designed to enhance the heart's ability to generate new blood vessels, protect them from a recurrent or a subsequent heart attack, and in so doing, enhance muscle function and improve their functional capacity. And one of the unique things that I say to patients is that unlike a drug therapy, maybe you become tolerant or there's drug-drug interaction or whatever else, if you have regeneration of heart muscle, only another heart attack is going to impair that. This effect won't wear off over time. It's not a blip and it'll go down. And there is clear evidence that this begins to see about 80% of the benefit at 6 months, and we use 1 year as an endpoint of probably the maximum benefit that you'll see. But it is translated into an improvement in functional capacity. That's what we're trying to do for patients, is improve their quality of life, day-to-day functional capacity. The CardiCAMP trial is a research trial, but in the criteria for eligibility, we want to make sure everyone is treated effectively and by guideline-directed medication. We spend a good several weeks making sure that we can optimize because people find that they're on the right meds, but they're not on the right doses. So we try to optimize that. We look for any other conventional things that could help improve the heart's function. I think one of the most important part of doing clinical research is to really sit down with a patient and this informed consent concept. What are they going to be asked to do? What are the potential benefits? What are the potential side effects? And I think the risk benefit of this trial in particular has a very finite amount of risk, of a small risk of perforation of the heart in delivering the cells, which is ruled out by an echocardiogram before they leave the lab. That is the entirety of the actual risk to the patient. It doesn't interact with medicines, doesn't interact with their blood pressure, and they're their own autologous cells, so there's no risk of rejection or problem with those cells staying alive. In contrast, the benefit is really very substantial. They'll have regularized follow-up, and what I say to patients getting involved in a clinical trial, that there's unequivocal evidence that being in a clinical trial, you'll do better than if you were not in a clinical trial. You have several other sets of eyes watching and just asking, anything wrong, what's going on, a couple extra tests that would not typically be done, but that may uncover something that wasn't noted before. I think it's really important, the risk benefit, and that's one of the strengths of this trial.